Hello and welcome. I'm Jody Fry. I'm a professor at the University of Maryland School of Social Work, and along with Dr. Sally Spencer-Thomas, we co-chair the Workplace Suicide Prevention Committee for the American Association of Suicidology. Today, we're just thrilled to welcome Dr. Deborah Stone, who is a lead behavioral scientist at the Division of Injury Prevention for the Centers for Disease Control and Prevention, or CDC, at the National Center for Injury Prevention and Control. Dr. Stone is a subject matter expert in suicide prevention. She focuses her work on trends, risks, and protective factors and prevention of suicide among high-risk populations. Her team encourages the use of a comprehensive approach to suicide prevention using public health frameworks and based on the best evidence available. We're so honored to have her here today to share some of the latest research from the CDC on suicide rates by industry and occupation, which has significant implications for guiding the work that we do in workplace suicide prevention. Before we get started, I just want to acknowledge that the Workplace Suicide Prevention Committee is a collaborative partnership between the American Association of Suicidology, the American Foundation for Suicide Prevention, and United Suicide Survivors International. Together with our partners, we're pushing forward the national guidelines for workplace suicide prevention, which are based on 8 guiding principles designed to help work organizations and professional organizations to make suicide a health and safety priority at work. You can see the 8 guiding principles on this slide, which are further detailed into 9 practices that go into specific steps, programs, policies, and initiatives that workplace and professional organization leaders can take in order to start your organization's journey on making suicide prevention a priority in the workplace. So without further ado, I'm going to turn this over to Dr. Deborah Stone. Again, we're so appreciative of you to share the most recent cutting edge research from the CDC, and we thank you.
I would like to acknowledge our esteemed lead author, Dr. Cora Peterson, also from the National Center for Injury Prevention and Control, and Dr. Peterson is also on the line with us today. I'd also like to acknowledge our co-authors and colleagues from CDC's National Institute for Occupational Safety and Health. Go to the next slide. Today, I will present some brief background on suicide, and then I will jump right into an overview of our paper, including a review of the methods, results, and discussion, and then we'll have time for some Q&A. Next slide. So suicide is currently the 10th leading cause of death in the United States. However, among people of working age, which we are defining as 16 to 64 years old, suicide is the 4th leading cause of death. In 2018, over 48,000 lives were lost to suicide among people of all ages, with 38,000 suicides occurring among people of working age. And between 1999 and 2018, suicide rates in the general population increased by 35%, and the rates in the working age population increased by 41%. Next slide. As we know, suicide is not caused by any single factor, but rather by a combination of factors occurring at the individual, relationship, community, and societal levels. So examples of risk factors for the general population include mental health disorders, jobs, financial, health, relationship, criminal legal problems, along with prior suicide attempts, loss of a friend or family member to suicide, and stigma associated with help seeking. Next slide. According to the literature, risk factors for suicide related to work may include low-skilled work, work-related access to lethal means, and job stress, which could include poor supervisory and colleague support, low job control, and job insecurity. And understanding which industry and occupational groups have high rates of suicide can inform suicide prevention efforts. Next slide. Our prior analysis examined suicide rates among major occupational groups in 2012 and 2015 in 17 states and looked at changes in suicide rates over that period. the occupational group with the highest male suicide rate in 2012 and 2015 was construction and extraction at 43.6 per 100,000 and 53.2 per 100,000 civilian non-institutionalized working persons, respectively. The largest suicide rate increase among males from 2012 to 2015 occurred in the arts, design, entertainment, sports, and media occupational group, with an increase of 47% from 26.9 to 39.7 per 100,000. And then the group with the highest female suicide rate was arts, design, entertainment, sports, and media, with a rate of 11.7 per 100,000 and 15.6 per 100,000. And the largest increase was in the food preparation and serving related group from 6.1 to 9.4 per 100,000 for a 54% increase. So those are just some brief results from the prior work. After this analysis, we received many inquiries, I should say, about specific industry and occupational groups and suicide rates in those groups. And that led to the study that I'm going to describe today. The purpose of this study was to analyze suicide data. We can go to the next slide, please. Was to analyze suicide data by major industry and occupational groups and among detailed occupational groups among working age decedents presumed to be employed at the time of death from 32 states participating in the 2016 National Violent Death Reporting System, and I'm going to call that NVDRS from here out. Okay. So suicide data for this study came from the 32 states participating in the 2016 NVDRS, and NVDRS combines data on violent deaths, including suicide, from death certificates, coroner and medical examiner reports, and law enforcement reports. And as mentioned, we analyze data by industry and occupation. And as you know, industry is the business activity of a person's employer, or if the person is self-employed, it'd be their own business activity. Occupation is a person's job or the type of work they do. So we looked at suicide rates by these different categories. Industry and occupation coding experts and our co-authors used what's called as the National Institute for Occupational Safety and Health Industry and Occupation Computerized Coding System. That's a mouthful. And that is called NIOX. And so these experts used NIOX to assign 2010 U.S. Census civilian industry and occupation codes for 20,975 suicide decedents aged 16 to 64 years from the 32 states participating in the 2016 NVDRS. Next slide. Suicide rates were analyzed for industry and occupational groups by sex. So we had a total of 15,779 decedents included in the analysis. These were primarily males at about 80%, or 12,505, and females at 21% at 3,274 decedents. And I would like to note that some decedents were excluded from our analyses, and these included military workers, unpaid workers, those whose NVDRS cases indicated no employment at the time of death, and those not residing in the analysis states. And you can see the numbers of people there that were excluded. The analysis was conducted using Stata and SAS software. Okay. So the overall suicide rate for the study population, as you can see here, for males was 27.4 per 100,000. And the overall suicide rate in the study population for females is 7.7 per 100,000. So suicide rates were significantly higher in 5 major industry groups as shown here. So again, this is major industry groups. So we have mining, quarrying, and oil and gas extraction occupations with rates of 54.2 per 100,000. Then we have construction, and among males, we see a rate of 45.3. construction also among males at, I'm sorry, I think I made a mistake here. Mining and quarrying 54.2, construction 45.3, other services, for example, automotive repair, the rate was 39.1 per 100,000. Again, this is among males. The next group was agriculture, forestry, fishing, and hunting. This group had a rate of 36.1 per 100,000 for males. And then transportation and warehousing, we see rates of 29.8 per 100,000 for males and 10.1 per 100,000 for females. So these groups had higher rates than the overall study population. Next slide. Rates were also significantly higher in 6 major occupational groups, and you can see those groups here: construction and extraction among both males and females, installation, maintenance, and repair among males, arts, design, entertainment, sports, and media among males. Then we have transportation and material moving among males and females, protective service workers among females, and healthcare support. And in terms of how these results compare to our last study, estimates for most major occupational groups were similar, although we can't really directly compare them, as the data in the prior analysis that I talked about earlier was based on data from the 2015 NBDRS with just 17 states. So we have these new results here. So next slide. Okay. So rates could be calculated for 118 detailed occupational groups. So now we're looking at those detailed groups for males, and then 32 detailed occupational groups for females. And some occupational groups with suicide rates significantly higher than those of the study population were only identifiable through observation at the detailed group level. So for example, farmers, ranchers, and other agricultural workers. And in other cases, both the major and detailed group were greater than in rates, than the rates in the general study population, for example, roofers. So again, you can see here the rates that I just mentioned for farmers, ranchers, agricultural managers at 43.2 per 100,000. And you can see that the major occupational group there, management occupations, the rate was 17.5. You can find results for other detailed occupational groups in our supplementary table number 2. And note that for many groups among females, rates could not be calculated, unfortunately, due to small numbers. Okay, so we can go to the next slide. And here again, we have just a few examples of some of the detailed occupational groups. And we can see registered nurses, for example, among females, the rate was 10.1 per 100,000. And then we also see among males and females rates for artists and related workers. And you can see that those suicide rates of 93.5 and 45.5 were greater than the major occupational group of arts, design, entertainment, sports, and media. And so we were able to only see that by looking at this detailed level. Okay, next slide. So this report estimated suicide rates comprehensively for industry and occupational groups, meeting sample size criteria, and identified groups with higher rates than the study's population rate overall. And it also showed relative comparisons of suicide rates. And what we wanted to mention is that while it's useful to look at relative rates, so look at one group compared to the other, we did want to note that the essential fact is that suicide rates in the U.S. working age population overall has increased by 40% in less than 2 decades. So therefore, all industries and occupations can benefit from a comprehensive approach to suicide prevention. And CDC's Preventing Suicide, a technical package of policy, programs, and practices, provides strategies with the best available evidence to prevent suicide, and can serve as a resource for communities and employers. Next slide. Okay. So this slide shows some workplace-specific suicide prevention strategies, including promoting help seeking, integrating workplace safety and health and wellness programs to advance the overall well-being of workers, referring workers to financial and other helping services. And then you can see the others here, for example, creating opportunities for employee social connectedness, reducing access to lethal means among persons at risk, and creating crisis response plans that are sensitive to the needs of employees and friends and family and others who might find themselves at risk. Next slide. So the findings in this report are subject to several limitations. First, this study did not address confounding factors that might account for different suicide rates among and within industry or occupational groups. It did not address suicide among unemployed decedents, military or unpaid workers, and those greater than 64 years. Third, the numerator and denominator data were not a direct match for calculating rates. Death certificates reflect decedents' usual industry and occupation, and available population size data refer to the number of persons by current job. Fourth, the results are based on data from 32 states and so therefore are not nationally representative. Finally, 3 states contributing to the 2016 NVDRS did not collect data on all violent deaths. And then there are other limitations of NVDRS, more generally, that you can find in prior works, including using death certificate data and how next of kin are often the folks that are reporting on these deaths. And so the data that we collect from NVDRS will be based on that next of kin, typically their report. So that's all I have, Jody. So I will hand it back to you.
Thank you, Dr. Stone, and thank you, Dr. Peterson, as well, for contributing to this report. And really thanks to the CDC for your leadership, not only in the surveillance data and understanding risk, but also helping us to come up with a multi-layered comprehensive plan to actually take action, including in the workplace. So we appreciate your presentation today. It's so helpful as we think about our next steps on the committee and with our partners in the workplace suicide prevention subcommittee. So again, I encourage all of you watching today to check out www.workplacesuicideprevention.com, where you can learn more about this study and the national guidelines to be part of the solution and take the pledge, like hundreds of other work organizations and professional organizations have already done, pledging to make suicide prevention a health and safety priority. Thank you so much for your time today.